Hello, everyone, and welcome to the webinar, Understanding and Addressing Occupational Disease Risks in Key Industries. My name is Paige Jones, and I'm the event specialist here at Workplace Safety North. We appreciate your attendance here today, and just want to let you know that your microphones have been muted, and we ask that you use the Q&A at the bottom of your screen for speaker questions. Questions will be addressed at the end of the webinar. A link to the webinar recording, a copy of the presentation, and resource information will be sent to you within the next few days. I will invite Judith on screen to introduce our guest speaker and begin today's presentation. Welcome.
Thank you, Paige. My name is Judith Nassen, and I'm an industrial hygiene specialist at Workplace Safety North. In 2023, WSN partnered with Occupational Cancer Research Center to develop occupational disease resources for the mining,
I think we may have lost Judith here. I think you're back now.
Okay, I'm going to continue. Together, we produced 3 posters detailing top risk based on data from the Occupational Disease Surveillance System, which monitors disease outcomes among over 2 million workers in Ontario. This is the first time the data were assembled by industry classification and communicated by poster infographic. Joining us today to discuss this data is Dr. Paul Demers. Paul is a director of Occupational Cancer Research Center based at Ontario Health and professor with the University of Toronto's Dalla Lana School of Public Health. He is an epidemiologist whose research focuses primarily on occupational cancer and lung disease. He has been a member of many national and international expert panels and communities dealing with occupational cancer for organizations such as International Agency for Research on Cancer, UN Environmental Programs, US National Toxicology Program, the National Institute of Occupational Safety and Health, and an American Conference of Government Industrial Hygienists. Please welcome Paul.
Thanks, Judith. Thanks for the introduction, and thanks to the organizers for inviting me here today. Before I begin the webinar, I just wanted to mention that the Occupational Cancer Research Center is based at Ontario Health, but is primarily funded by the Ministry of Labour, Immigration, Training and Skills Development of Ontario, as well as getting funding from the Ontario Ministry of Health and a number of different competitive granting institutions. Can I have the next slide, please? I think there's a lot of awareness now about the importance of occupational disease, which I think people are much more aware now than they have been in the past. You can see here some statistics from the WSIB, over 40,000 allowed claims in 2022, worth millions or tens of millions of dollars. But it's important to recognize that a lot of occupational disease is not compensated, is not recognized at all. And that's because occupational diseases often arise a long time after people are diagnosed, or people are a long time after people are exposed. And so we say they're long latency diseases, and some take decades to develop. Certainly cancers, that's the case in some lung diseases. And then many of these diseases have multiple causes, and that makes them much more complicated. So workers' compensation statistics only really reflect a fraction of what's really out there. So it really doesn't give you the full picture. And I want to stress that this isn't a problem just of Ontario or a few industries. It really exists across many different compensation systems in many different jurisdictions. So it's important to remember that that's the case. But we developed the Occupational Disease Surveillance System to try to give us that bigger picture and really give us an idea of what the full scope is of the problem of occupational disease. Could I have the next slide, please? So as Judith already mentioned, we have over 2 million people in this system, and we created this system using records from the WSIB, records of people who've formerly been compensated for other things. But we really created it so that we could follow people over a long period of time and look at new diseases that are being occurring in these folks that are unrelated to what they originally got into the WSIB records for. So many of these folks may have entered for different types of acute injuries at work, and then we're looking at things like cancer, lung disease. I'm going to apologize. You're hearing a helicopter land on the hospital next to my office, but it'll be over in just a minute. We do this by linking those records for now around 2.4 million workers to the cancer records of the province, hospital records, emergency department records, also the outpatient physician records. So when you go to doctor's office, for instance, and there's an electronic billing record, we're also able to access that, and even lab test results. And we're able to do this because we sit within Ontario Health, where we have the highest data security in the province, and we're able to do things very securely and very anonymously. So we never see anybody's names, and we're only allowed to report when there's a sufficient number of cases. But this huge data set that we've put together allows us to look at literally hundreds of different occupations and industries. Can I go to the next slide, please? Now, some of you who have visited the Workplace Safety North website or received some of the materials in their occupational disease campaign earlier this year will probably recognize some of the symbols used here and some of these diseases. What I'm going to talk about today is not all the diseases that we saw increased, but really the ones where we understand what causes those diseases and where we could really focus in on for prevention. So in mining, that certainly includes lung cancer, different types of chronic lung diseases, chronic obstructive lung disease, silicosis, and other types of fibrosis. We're also looking at some of the diseases that impact people's ability to work, including carpal tunnel syndrome, which I'll explain about for those of you who don't know it, and Raynaud's syndrome. And we're also going to talk about acute myocardial infarction, which is really the medical term for heart attacks. We can't look at every disease, unfortunately, and so you'll see, I wanted to stress that hearing loss is an important occupational disease. It's an important source of impairment for a lot of workers, really impacts people's lives, but we're not able to look at that in the kind of records that we can access. Can I go to the next slide, please? Can I go to the next slide, please? Thank you. So for different forest industries, you'll see similar types of diseases, including the lung disease, lung cancer, acute MIs, and these carpal tunnel syndrome and Raynaud's syndrome. Now, the source of those diseases may be different than they are in mining. Sometimes they overlap in the causes, but we see a similar set of diseases that arise, and these are ones that we see as occupational disease in a number of different industries. Can I go to the next slide, please? So lung cancer is what I'm going to start with. Sorry, another helicopter. They don't actually take off very often from here, so I hope maybe you're not hearing it as much as I am. Lung cancer is what I'm going to start off with today, and that's in part because I'm with the Occupational Cancer Research Center, so it certainly is something that I often deal with. Approximately, lung cancer is our most common fatal cancer, and it's important in both men and in women. We still, most people still don't survive when they get when they get lung cancer survive more than 5 years. So it's a bad form of cancer. Approximately 15% of all lung cancers in Canada are due to workplace exposures. And so that may not sound like a huge amount, but that's thousands of lung cancers every year that are caused by work. And the causes of these lung cancers include diesel engine exhaust from heavy equipment, which can be used both in mining and in forestry. Respirable crystalline silica, which is common in mines and quarries, and at least when I was doing work in British Columbia mills, we would also see it in yarding operations where a lot of dust can often be blowing around in yards. Nickel is also a lung carcinogen, which we've seen from studies of smelter workers primarily and related workers, but nickel is a recognized cause of lung cancer. Radon is an important cause of lung cancer across Canada from residential radon, but workplace radon is also an important cause of lung cancer. And it was very important in the uranium mining industry in Ontario, which isn't operating anymore. But radon can still be found in some underground mines, although not at the levels that we saw in uranium mines. Now, many people don't know or may have forgotten that we had asbestos mines here in Ontario, not as many as Quebec. They were smaller, but they were not good places to work, and they've all closed down long ago. And so we do see asbestos-related disease in former asbestos miners. But asbestos is also used in places like the pulp and paper industry or other places where we need to, insulate against in hot environments and things like that. So it is still a thing that happens in that industry. Can I go to the next slide, please? So I'm not going to present a lot of tables that look like this, but I wanted to talk about where our statistics come from. When we look at things in the Occupational Disease Surveillance System, we're comparing people in one industry to all other workers in the system. So we're not comparing to the general population, we're comparing to other working people. And that's important because we think it gives us a more valid, a more true picture of what the risk of disease is. Could I get the first highlight here? What our statistical analyses pull up are things called hazard ratios. And that's the risk in the group we're looking at compared to all other groups. And so you see here below 1.40, that means that's what a hazard ratio looks like. We also get 95% confidence limits, which if you could highlight the next thing. And that gives us, people probably hear a lot of that in the context of different types of surveys, including political surveys and things like that, where we say, 19 times out of 20 or things like that. It's to give us an idea of the statistical significance of what we're doing, that it isn't just arising from chance. I won't be presenting those today, but everything I'm presenting today is what we would call statistically significant, even though I don't mention it. Now, if you could hit the button one more time. So as an example here, we get lung cancer, that overall in mining, we have a hazard ratio of 1.4, but that means there's a 40% increased risk of lung cancer among miners overall compared to other workers in this industry. And then you see the 95% confidence limits there, which just indicate that this is highly statistically significant, that the true number we're sure or we're very sure operates somewhere between 1.3 and 1.5. So I'll go on to the next slide. What I'm going to be showing people more here is results presented where I give the increased risk among that group compared to other workers, but I present it as a percent increased risk. So you see here the risk of lung cancer among mining uranium miners is it's twice what it is in the general population. So that's the hazard ratio. So we say it's 100% increase in uranium miners. And it's similar in stone quarry workers. And what these two groups have in common is crystalline silica, which is high in the old uranium mines. And the uranium mines, in addition, had the radon levels that were quite high. And probably both of these groups have exposure to diesel engine exhaust, which is being emitted by heavy duty equipment. Now, we also see relatively high levels in gold mines, which have similar, they also have an increased risk due to crystalline silica, not quite as high as uranium mines. Many of them are underground, used diesel equipment as well. And we see that in sand pits and quarries, less than in stone quarries, but still elevated. And then we see lower, but still elevated levels in nickel mines, but also in logging and in sawmills. So we do see an increased risk of lung cancer across many industries. Can I go to the next slide, please? Now, I'm not going to talk in as much detail about other cancer risks, but I will say that we see larynx cancer increase in a number of these industries as well, but it's a much rarer cancer. So we're less sure of those increased risks. But even though we know less about the causes of larynx cancer because it is rare, we suspect it has many of the same causes as lung cancer, which may be why we're seeing it increased in a lot of the same industries. We see an increased risk of mesothelioma among our former asbestos miners, which is a significant thing, but again, based upon small numbers. And we see nasal cancer, which is also related to nickel exposure, increased among nickel miners, but again, based upon very small numbers. So we have less certainty for these types of cancers, but I wanted to mention them as well, because there are ones where we have seen them elevated in other similar groups. Could I have the next slide, please? Chronic obstructive pulmonary disease, or COPD, which I think many people may have heard of, is one of the most common chronic respiratory or lung diseases in Canada. And it's also one of the leading causes of death in Canada. So certainly as people get older, COPD becomes an important cause of, or potential cause of death. Now, the American Thoracic Society and the European Respiratory Society are two of the most well-respected organizations in the world for physicians that specialize in lung diseases. And they estimate that approximately 15% of COPD cases are caused by workplace exposure. So similar to lung cancer. Now, this is important because I think for many non-specialists, they may think of COPD as primarily just being a problem of cigarette smoking, which is a major cause of COPD, but it's not the only cause. And in fact, among never smokers, almost a third of the COPD among never smokers, so people who never smoke cigarettes, is thought to be due to workplace exposures. And it can be caused by a variety of dust, fibers, fumes that exist in different workplaces. So it seems to be related to really kind of a wide range of different hazards that you can find in many heavy industries. Certainly mineral dusts, including silica and asbestos, are associated with it. Diesel engine exhaust, so two things we also mentioned for lung cancer. But organic dust, that is dust that come from that have a source of living things. So that includes wood and paper dust, are also hazards for the lungs. and a number of different chemicals that can also irritate the lungs, including things like formaldehyde, are also hazards for breathing. Can I go to the next slide, please? So what you see here is the risk of COPD in these major presenting mining first, and you could see across lots of different mining, you see an increased risk. But particularly in some of these groups that are extremely dusty. Quarries can be very, very dusty. Contract drilling, some mining services can also be very dusty. And those can lead to chronic forms of lung disease. And when we say chronic, they're diseases that can develop and get worse over time if we don't stop exposure to things like dust. Can I have the next slide, please? Now, we also see it in forestry and pulp and paper. Now, I don't know a lot specifically about the wooden box industry, but for some reason, we get very high risks in the wooden box industry. I'm going to suspect that it happens to be very dusty, but I'm not sure about that industry. It's certainly, this was a surprise to us. But sawmills, veneer and plywood mills are things that we've seen in other studies in other parts of Canada and say the Nordic countries or Scandinavia, which have similar forests to ours. So we also see an increased risk in pulp and paper industry as well, although not quite as large. So a lot of other dusty parts of or dusty areas of industry where we know that there are hazards to breathing. Can I go to the next slide, please? Another kind of group of different lung diseases are what we might, refer to as restrictive lung diseases. Now, they're different from the obstructive lung diseases where the channels are being blocked for breathing. The restrictive ones mean that our lungs aren't as, they don't move as well as they should. And that's because of scarring of the lung that can occur from exposure to things like crystalline silica, which causes a lung disease called silicosis, asbestos, which causes asbestosis. And we have other specific names for other types of lung diseases caused by specific types of dust. But there's a similar kind of group of diseases that fall under the name of idiopathic pulmonary fibrosis. The term idiopathic means that when they're diagnosed, the physician does not know what they're caused by. It doesn't mean that they aren't caused by something. It just means that they don't know what caused it. And again, there's two big specialist organizations, the American Thoracic Society and the European Respiratory Society, have looked at this issue and think that about a quarter of these things that are not recognized, we don't know what caused them, are actually caused by work. And they're simply unrecognized work-related lung disease. And they've seen that because studies that have actually done in-depth interviews of patients with those have identified metal dusts, mineral dusts, including crystalline silica, these organic dusts, which also cause COPD. And again, more broadly, exposure to a wide variety of things that cause impaired breathing, like COPD, can also lead to these other diseases, to lead to different types of fibrosis. Can I go to the next slide, please? Now, this isn't an error. These are the increased risks of silicosis. Earlier, I mentioned that one of the problems of identifying work-related disease is that many of the diseases we're looked at have multiple causes. Silicosis is not one of those diseases. Silicosis is caused by exposure to crystalline silica, which scars the lungs. So what you see here is that in mining overall, we have 10 times the risk of silicosis, and then higher levels in uranium mines, particularly, and in gold mines, where the levels of silica are much higher. Still an increased risk in other metal mines and in mining services, but not as high. So very, very high risk, but that's because it's very, very rare outside of jobs like mining or other ones where there are very high levels of silica exposure. Can I go to the next slide, please? When we look at idiopathic pulmonary fibrosis, we see some other industries, some of the same industries and some other industries that are increased. And that may be because we're simply not recognizing those diseases. It could be that people leave mines, they're away from them for a long time, and maybe their doctors are not aware where they worked, or people are not suspecting that that's the cause of their difficulty breathing. But for whatever reason, we are seeing increased risks. Not as high as silicosis, because idiopathic pulmonary fibrosis can be caused by other types of problems as well. But still an increased risk in gold miners, uranium miners, mining services, and then also in some of the forest or wood-related industries. Can I go to the next slide, please? The last kind of major, what we call chronic disease, one that develops over a period of time in general, is this heart attacks, acute myocardial infarction. And it's not something that everybody thinks of as being work-related. But in fact, studies have identified people at increased risk of heart attacks from exposure to high levels of noise, which are common in both the forest industries and as well as mining, particularly in underground, where things kind of can bounce off of the walls, but also lots of different areas of mining where you're drilling and other equipment is making a lot of noise. And in different areas, even in pulp and paper mills, where there's also a lot of background noise. Now, it's also believed to be related to diesel engine exhaust and fine dust and particles. Now, many of these things, we see it in people's increased risks of heart attack, but we also see it in other forms of heart disease. And a heart attack is, doesn't usually arise in somebody who doesn't have other types of underlying heart disease. So it is kind of a long-term issue, and we do think that it can be prevented by reducing exposure to these things. Can I go to the next slide, please? And what we see is an increased risk of heart attacks in some industries, although not in all. And so you see an increased risk here in gold mines and uranium mines. You see a little bit in nickel mines, but that's not statistically significant. We don't see it at all in non-metal mines, and not necessarily in mining services either. One issue is that people move around a lot in mining, and that maybe that they've been in different areas of mining. Even though they might stay in the mining industry for a long time, they might move to different types of mines. Or it just may be that these older sectors, mining sectors, gold and uranium, may just have just been around for longer. But we do see it across a lot of different industries. And so this does raise concerns about the risk of heart disease in some of these different groups. Let's go on to the next slide, please. So we do see it also in the forest sector, where we do see it across a number of different groups that you see here. So it's another one of these things that is in common in what might be two different kind of really very different workplaces in how it might look to people, but they face in a way kind of an overlapping set of hazards. I'll go on to the next slide, please. I'm going to switch gears a little bit here. When we set up the Occupational Disease Surveillance System, we were thinking we were going to be looking primarily at diseases that arise over a long period of time. But people have asked us to look at some of these other diseases, and these are two that popped up a lot amongst workers in the kind of northern industries of mining and the wood-related industries. Carpal tunnel syndrome, which is an important cause of impairment for people's hands. It's caused by what we call compression, or kind of a squeezing of the nerve in the wrist that really controls the hands. And so people feel numbness and tingling in the hands and pain. And it can be caused by repetitive, so doing things over and over again, which require awkward, like bent wrist and things like that, and a lot of forceful hand movements. It's also related to exposure to vibration, and sometimes to mechanical stress. So things that cause pounding on the palm of the hand can also hit that same nerve that really impacts the fingers. Now in the ODSS, because of the kind of health records we have, we're only really able to identify very serious cases of carpal tunnel syndrome. So we're not seeing the kind of full range of these kind of problems, but can be very debilitating and cause people to have to change jobs. Raynaud's is a different type of disease. We also call it white finger or vibration white finger. It's caused by kind of hand-arm vibration, exposure to cold, and what people get is similar things of kind of numbness and tingling, but also you see that the fingers may actually go white. And it's also a very debilitating disease for people who have it. We certainly saw it historically in a lot of people who operated chainsaws that would certainly give you a lot of hand-arm vibration. But about 80% of the Raynaud's syndrome or white finger here in Ontario that's compensated by the WSIB is actually in the mining industry. So it's well recognized in the mining industry as well, where we can also have exposure to vibration and certainly cold. Can I go to the next slide, please? So we do see it here in certainly in mining and quarrying. Even though a lot of it is recognized, we still see an increased risk compared to other workers. So there may be some unrecognized cases that arise there. And we see Raynaud's in forestry and logging still, less carpal tunnel syndrome there. So I've done here a little different. I've made I looked at these groups kind of side by side, with the blue here as being Raynaud's syndrome and the orange being carpal tunnel syndrome, which are both elevated in mining and quarrying, but they don't necessarily follow each other in the same industry. So we see more CTS, carpal tunnel syndrome, in wood processing and pulp and paper. So I'll go to the next slide, please. Now, I said I wasn't going to present a lot of things like this. This is some statistics that we just pulled up from when we've done work with what's called the mining master file. So it's one of our historic data sets. Would you mind hitting the slide again? This gives us the ability to compare when we've done analyses of these, where that SIR means the standardized incidence ratio, but it simply is a measure of the risk of disease amongst these miners compared to the general population of Ontario. What you see in the background here is the miners' memorial that exists in Elliott Lake for the uranium miners and that have been employed in that industry, and people who have died of lung cancer there. But I'll say that the reason I put this up here is that the risks of these diseases, this is nothing new when I've been talking about for some of these diseases. We've known about them for a long time, and things are definitely getting better. When we look at these old studies, we see very high risks of some of these diseases. But in the more modern records that I've been presenting today, we see lower risks, but they haven't gone away. So we are making progress, but we have to continue to make progress. Can I go to the next slide, please? Now, the internal responsibility system and working with joint health and safety committees and health and safety representatives is extremely important for the control of occupational diseases, as it is for the control of any types of safety hazards within industry. But as a hygienist, and I'm trained in both hygiene and in epidemiology, although most people think of me as an epidemiologist, we often think of things in the context of called the hierarchy of controls, that we want to, if possible, eliminate hazards altogether or substitute less lower risk ways of approaching things, or lower risk substances for high risk substances. If we can't do that, we talk about engineering controls or administrative controls. And then really the bottom of the list for us is personal protective equipment, because that provides, while it might be the only resort in some situations, it should always be the last resort. We should try to prevent these hazards from ever potentially causing harm and not have people rely upon things like wearing masks. Go to the next slide, please. Now, this is an infographic that our center developed and that we also worked with Workplace Safety North on to look at diesel exhaust in underground mines, which is one of the most challenging things to prevent. And I can't go into this level of detail for all these different hazards, but what we're trying to think of is, what can we do in terms of eliminating things out, or trying to use equipment that maybe doesn't use diesel fuel. Replacing old equipment with other equipment that doesn't use diesel. If we can't do that, and that's a long-term solution, then trying to do things like increasing ventilation or making sure that we're maintaining our equipment to the best degree possible to control things. There's other types of technology things, different types of filtration that can happen right on the machine that can prevent the diesel from going into the air. So you see here lots of different examples, but we also tried to think of whether they were eliminating exhaust before it got into the air, which is what we really are aiming for, versus allowing it to get into the air and then having to remove it afterwards, which is not as optimal. So we'd rather prevent the exhaust from getting into the air in the first place. Anyway, I invite people to find this graphic, which you can come to our website, or let me know and I'll direct you where to find it. Can we go to the next slide, please? So just to give you, some more just examples, elimination and substitution, which is optimal, is challenging, but it's still possible in many cases, such as replacing diesel equipment or replacing vibrating tools with lower vibration tools. Certainly there's other examples that are out there. Engineering controls are more often possible general ventilation, which can happen in a lot of the different workplaces we're looking at. Redesigning of workplaces, workstations to reduce ergonomic hazards. So hazards that might impact, risks of hand and problems with the hands and things like that could sometimes be done through different engineering controls. Administrative controls, that is trying to put and create workplace rules that if we follow them, make things safer, can have some limitations. They really require that people follow rules, and that's not always easy to do, and it's not always natural to do, even though it can protect people. But for instance, in many areas of the forest industry, within mills, making sure that we're properly cleaning up dust, not by blowing it around with compressed air, but by removing it with vacuum systems or wet systems. Vehicle, turning off vehicles when we're not using them, so they're not idling and generating exhaust in the air when it's not necessary. Training certainly would fall under that. And then, as I said, personal protective equipment, masks and things like that are the last resort. Go to the next slide, please. Now, the conclusions for what I've been talking about so far is that I wanted to bring up here at the end. One is that the results I'm presenting you are from surveillance studies, and that they have some limitations. We don't have information on the cigarette smoking habits of the people that are in different industries. We don't know a lot about individual risk factors that they might have from other sources. But it is stronger than many other approaches that are used because we're comparing workers in specific industries to all other workers in the province. So that does actually help in our ability to look at this. And the size of the system that we created gives us the ability to look beyond workers' compensation statistics. Although levels of many hazards have decreased over time, increased risk of these occupational diseases remains. So we really have to keep awareness up, and we have to keep up our efforts to decrease these diseases. Another thing that you've probably noticed from the slides that I presented is that many of the hazards that we're talking about, they really don't cause a single disease, but they can cause a number of different diseases. So if we control things like silica or diesel exhaust, or noise or vibration, they'll have positive impacts on more than one disease. They can have impacts on multiple diseases. So we do get a lot from those. Now, I just wanted to talk about something else for another few minutes, and then we can go to question and answers. So could I have the next slide, please? Some of you may have seen or heard this news release from the province of Ontario about strengthening occupational illness protection. And one of the things raised in that is creating an occupational exposure registry and doing other things to reduce the risk of occupational illnesses. But I'm going to focus in on exposure now because exposure is extremely important when we're dealing with occupational disease. Can I go to the next slide, please? Now, at the Occupational Cancer Research Center, we're using the initials more because we really deal more broadly with occupational disease than just cancer. But we have tried to create we're creating an exposure data system. And I want to talk about why we're doing that and how we need the help of all the workplace partners in order to do this properly. There are a number of important questions that we need to answer when we're doing prevention. We want to reduce exposure levels down to where they are not causing occupational diseases. But how do we know that? How do we know that they're low enough in order to be safe? We have to measure them. We have to measure them in some ways. Are levels dropping over time? Do we know that? Maybe some people within a specific workplace may or may not know that. More broadly, though, in the sector, we may not have a good picture of where that is. Nor do all the workplace partners know that necessarily. And knowing these patterns and trends about which groups are at high risk and what levels are doing is important in order for us to really direct prevention efforts. And the only way we can know that is by monitoring the levels of exposure. Now, for a long time at our center, we have been proponents of, I've used the word digitize, which people may or may not have heard of, but a lot of the records that are kept historically were all in paper. They're not things that we can use to rapidly pull up numbers and figure out things. We live in the computer age, so we want to create computerized databases in order to be able to track these hazards and to know where they're going and looking at their patterns. So the purpose of creating our system is really to create an electronic system that will allow us to support both prevention and policy development within the province of Ontario. So we're working with the ministry to initiate the development of this exposure data system as part of their kind of exposure registry initiative, beginning with the data held by the ministry. And that would be data from inspections, workplace inspections over time. Go to the next slide, please. But workplace inspections only give us a small slice of the bigger picture of what hazards are out there and what the levels are. That's because inspectors are really just called in when there are problems or suspected problems, and they don't do any sampling at all anymore. Historically, they did their own measurements, but now they simply often ask the employers to do that. But what that means is that we only get this kind of small view, and it's kind of a distorted view because it really focuses in on the problem areas, and even then we don't have data on all the problem areas. So in order to get the bigger picture, we need data from that's being collected either by employers, different companies that are out there, particularly the larger ones, or by consultants that might be hired by smaller workplaces or even by larger workplaces in order to collect a lot of measurements. So there's a lot of data out there that we think might give us this bigger picture of how exposures look within the province. But we really need the cooperation of everybody out there in order to get that big picture view and know just how we're doing and where we need to focus our efforts. So what we're doing is starting this initiative, starting with MLI-TSD, or Ministry of Labor, as we've called them historically, data, where we're extracting data from their records and cleaning it and putting into our electronic database. But we'd also like to get data flowing in from other places. Once we have that database, we want to create, it allows us to generate the statistics that we need to help direct prevention and provide specialized reports based upon looking at some particular hazards, and allow us to look at and do more in-depth research on hazards. But it's also going to allow us to create a system where we can make that more publicly available, not on the workplace level, but more on the queryable database that might say, what are the average levels in a particular industry or in a type of workplace for these different types of things. And that can be accessed by, we say public, but it'll be really accessed by our different workplace partners can be able to kind of answer the questions themselves and pull up the kind of data that they want. That means that if you're in a particular workplace, you might see, well, what are the average levels that are seen in the industry? And are we better than that? Or do we have some ways to go? And are there other ways that we could learn from other workplaces? So this is an important component of, I think, a more sophisticated approach to prevention. So I think with that, I am done. If we go to the next slide. I'm going to turn it back over to my friends at Workplace Safety North. I think.
If we still have Judith, she should be coming on. So we may have lost Judith. So I just want to let everyone know October is Healthy Workplace Month. So we have a role to play in ensuring healthy work environments. And there are many tools and free resources available from Workplace Safety North to support you. So on screen, you'll see a list of the resources that we have available, and we will share this with you after the webinar. So we have resources on occupational disease prevention, including articles, videos, training, and resources. The occupational risk posters that were mentioned today in the webinar. We have industrial hygiene assessments and silica control tool as well from OCal. So as well be shared with you. And we have Judith back. So it doesn't look like we have any audience questions. So I'll just turn it back over to the speakers for a moment. If there's any final thoughts you'd like to leave with our audience before we wrap up. And Judith, maybe I'll start with you.
Sure. Thank you very much for stepping in for me. The internet is not very stable. But in the end of the story, the message what I've like to bring out to everybody, and most especially for the workers, that we have so many more people are dying or injured or developing some kind of illness due to occupational diseases, like long-term exposures that we don't feel every day, but we tend not talking about it so much. But Paul mentioned that it is so much significantly, so much more people are exposed to those hazards and have adverse effects to it. So it's time for us to really bring it up to the same level of importance as acute injuries would happen, health and safety related acute injuries in a work site. So any kind of presentations or education sessions are the best way to go about it, to bring up the awareness amongst all of us that the importance of reducing occupational disease. So thank you, Paul, for developing this slideshow. That was really great. Thank you.
Thanks, Judith. So you see here, this is the OCRC at ontariohealth.ca is the email for my center. They'll pass things on to me or try to answer questions or point people towards resources if you do have any questions. So I encourage you to use that. But if there's any questions now, I'd be happy to answer them. Otherwise, I'm also happy to let everybody go on with their days.
Wonderful. Thank you so much. So I would just like to thank Paul and Judith for joining us this morning, as well as our audience. As a reminder, a copy of the presentation and the recording will be emailed to you within the next few days. And so we'll give a few minutes back to our audience. So I'd just like to say thanks again for joining us and have a safe day. Take care.
Okay. Thanks, everybody.